Could erosion be a factor? And yet we're going to look at all these things at every one of our patients that we have any kind of wear. We're going to ask these questions. What's causing it? Could it be erosion? Sometimes it is erosion. Sometimes it's GERD. Sometimes it's, if you've heard some of the lectures Jay Levy has given about people mulling fruit, I didn't really realize that people did that until I started asking them. But sometimes it's too much citrus. Sometimes it's GERD. But would you feel comfortable putting veneers on this guy? He comes into you and says, hey, I want to look good. I've gotten, my kids are grown. Maybe I'm looking for a new relationship. Maybe I want to keep the relationship I already have. I want my teeth to look good. So would you feel comfortable putting veneers on this gentleman? Well, what about sleep apnea? We have to ask that question every time we see a case where the teeth are worn. This is another young man. What's causing it? Is it just occlusion or could it be sleep apnea too? Well, is there evidence in these pictures that the occlusion is just not working for the patient? And that's the question I want you to ask yourself when you see these patients. When you see this and someone says, well, look, I'm 60 years old. Teeth are supposed to wear out. Well, guess what? I just showed you when I graduated school. No, your teeth are not supposed to wear out. Mine haven't worn out. But some people think, and some dentists think, that that's just a natural part of aging. But your enamel is the hardest substance in your body, the hardest. Your dentin is 7 times softer. So once you break through, if you can see my cursor, once you break through the enamel, getting the dentin, it wears much more. So is the occlusion working for this patient? What about this guy? Well, you'd say, well, he's wearing a denture, so of course it's worn. But look at the super eruption. And the point of it is someone gave this, or he chose this and said, I want you to stop here. It's obviously not working for him. What about these patients? And I know, being a dentist the years I have, and I know the audience, we see this all the time. Broken molars. We see broken dental restoration, whatever ceramic it is, whether it's Emax, zirconia, or old porcelain. But do we have a greater responsibility besides just choosing stronger materials? I mean, do we just say, well, we just have to get better zirconia, better Emax? What about when they come debonded? Have you ever had a zirconia crown debond? Have you had a zirconia crown break? I have. Wait a minute. What about the tooth below it? What if that tooth doesn't break, but the occlusion is not working and the teeth below it break? So the question is, do you have a greater responsibility besides just trying to choose something stronger, harder, that sticks better? Well, this patient came in my office. She's a physician and her daughter's a dentist. Now, her daughter did not do this case, but her daughter had come to a course and recommended her mom come to me, and another dentist had done this restoration. This kept debonding. And she said, I want your best cement. And it's like, well, we all buy cement from the same cement store. But look at the lower teeth. Is there any evidence that the occlusion is probably not working for this patient? And the answer is yes. So I re-cemented it and we got going with records. And we had some more work to do. Now, whether we like it or not, we do have 2 different populations in a general practice. On one side, on the left, everything's working for the patient. The size, the contour, the teeth, the speech, phonetics, everything's working. On the other side, well, the size of the teeth, the contour, the position, missing teeth, whatever is not working. The ones on the left we call our general patients. The ones on the right are our specialty patients, and it takes 2 different approaches. So with the specialty patients, our first job is to recognize what's not working properly and to acknowledge that it is not, because teeth are supposed to last a lifetime. And I'm going to point out again, my teeth last a lifetime. They haven't worn and chipped and broken, but I had occlusal therapy. The second one is, if it's not working, where should the teeth be in space for aesthetics, phonetics, and function? That's the next responsibility we have. And the third responsibility we have is to help patients based on their need and any other life obstacles they had. So that's what I think our responsibility is, instead of just finding a stronger, more magic bullet type restoration or cement. I'm going to introduce you to Steve, and this is the case we're going to talk about tonight. Steve's given me total permission to share his case. In fact, when I did his case, he knew I taught, and he really was passionate about the fact that he wanted me to help other dentists learn what had happened to him. Steve and I became friends a long time ago when I coached this kid in baseball in Little League. And Steve was a really good athlete and a baseball player himself. He was an executive in a banking institution in Lexington, pretty high up, actually. And just great guy. But he hadn't been a patient of mine. Lexington's got 350,000 people, but we were friends. And I would see him on an infrequent basis because we liked to go to the same restaurant a lot. So one night I was there and Steve was there and we were talking. And he says, "Hey, I'm thinking about getting some dental work done. How much do you charge for a crown or veneer?" Well, don't you just love it when people get you and you're out at a restaurant and they ask you, "How much do you charge?" Because, and I told him, it depends on what you are interested in. But if you're just talking about a single crown or veneer, I gave him my fee. And he went, "Wow." He goes, "That's like $600 more than the estimate I got from the dentist I've had. I want to get all this aesthetic stuff done because I don't like the way my teeth have worn and chipped. And man, that's a lot." And I said, "Well, Steve, it's like you're a director and you've worked your way up and you're pretty good at what you do with investment banking. And your case could be pretty complex just by sitting here at the bar in the restaurant talking to you, the chipping and the wear that you've got. So if I can help you, let me know." So about 18 months ago, he let me know. About 18 months later, he let me know. Steve calls me up and he says, "Hey, remember that night we were at the restaurant?" I said, "Yeah." He goes, "I got this veneer that keeps coming off and I want you to take a look at it." So he came in to see me. Now, at this point, he had had 8 lower ceramic restorations and 8 upper ceramic restorations. And this veneer had come off 3 times in the first 6 months. So, of course, what did he say? "Hey, what's going on here? Get your best glues or something." I mean, I can't understand why this keeps coming off, but maybe I thought you could glue this back on with a better glue. Well, I'm looking at it and I'm thinking, all right, first off, I hope you can see my cursor. Here's a bunch of glue she left on, but look at this posterior occlusion. And so I'm talking to him and I'm going, "What's going on?" Now, when he's in MI, some of these teeth hit, but even then, not all those teeth hit. And of course, I checked him in centric relation, being a Dawson dentist, and he only had 2 teeth touching on the left side, quite a bit of slide. He goes, "Well," he said, "see, I've ground my teeth all my life, and I wore a bite guard, and I had worn them down, and they didn't look good. So she's trying to make them longer, and she told me she was going to open my bite and make sure that I could tolerate it." I said, "She said, you're going to open your bite?" She goes, "Yeah." And that's why the back teeth haven't been done yet. And he says, "I'm sort of getting used to it. I haven't got a new bite guard yet. I'm used to wearing a bite guard and I'm not having headaches. So I'm probably am grinding my teeth at night, but it doesn't feel even, but we're just kind of waiting and seeing." I said, "So she opened your bite and that's where we're at." And he said, "Yes." Well, so now I said, "Okay, Steve, I'll cement this back on with my very best glue that I got from the same glue store that the other dentist did, I'm sure." But I cemented back on. I said, "Listen, I think you got some problems with your bite, and I didn't see your teeth in the dental office before. I saw them in the restaurant and they were worn, but you've got some significant bite issues going on where these back teeth don't touch. And I know for sure you're going to have to finish this case." And he goes, "Well, I'm not sure I have much confidence in her right now with this one coming off. I'll think about it." I said, "Well, I'm not telling you to switch dentists. I'm telling you got a bite issue. That's why this is coming off. It's not my glue, and it's probably going to come off again." Fair enough. So about 2 weeks later, guess what? Phone rings. It's Steve again. And you know what I'm thinking? The veneer came off. I was wrong. That's number 7. Number 7 broke. It was a post and core, and it didn't just come uncemented. You see that little red up there? It actually fractured the tooth. And so he goes, well, now this one's coming off. Can you cement that back in? I said, hey, first off, there was tooth structure at the margin broken. So it wasn't just, and I said, Steve, this isn't going to stay. And you're likely going to lose the tooth. He's, lose the tooth? What do you mean I'm going to lose the tooth? I said, well, you've broken the tooth under the gum line. It's had a root canal. It's a small root to begin with. It would need crown lengthening. I'm not sure, but I'm betting that you may end up losing this tooth one way or the other. And I know for sure this is not going to stay because I can't cement tooth to tooth like this, but I can put it on today temporarily. I really think you need to either talk with your dentist or come in here for some records. He goes, you know what? I've had it. I'm going to come in and see you. Let's do some records. What are you talking about? Well, what I was talking about is we took the 21 photos that some of you may be familiar with. A lot of different organizations teach it, but this is the protocol we have for the Dawson Smile Wizard. And I think at that time it's called the Dawson Diagnostic Wizard. Now that has been sold. Dawson Academy does not own it at all, have any financial interest. It's called the Smile Wizard. But what we do with these 21 pictures is we take the pictures and the camera is set on a manual focus. And the reason that's important is I'm coming in and out, and when it beeps to focus, that's when I take the picture. I want you to remember that, but this is very important for this software, and you'll see what I mean in just a minute. So we took a whole series of photos. Here's a little bit more close up. And, you know, some of these you can see as I imported this. But looking closely now, I picked out 5 teeth that had chipped, including number 8 had chipped. These teeth seem really long relative to his facial structure. These almost had been adjusted. I don't know if you can tell, but his teeth overlapped to here, and there was no incisal edge. They were almost like butter knives. So instead of having a good incisal edge on those lower centrals, they were almost like if you had a butter knife sticking up there. You can see it from this side. You can see the chipping on the edges. And when we added everything up, it was like, what's going on here? And this is in MI. When it was in centric relation, it was worse because only 2 teeth on the left touch. So, you know, now we're saying, okay, we got to really focus here. So now we go through the wizard and we do our exam summary. So his aesthetic concerns actually were medium. He said, these look okay, but they're breaking. And when I got really close to my camera and I said, you have 5 different teeth that have chipped porcelain. And you've had this one come off 3 times, and now you've got a tooth broken at the gum line. So we knew he clinched and grind. We knew that MI did not equal CR. We knew that this was a severe issue. We also could tell by looking at Steve, he really wasn't a class 1 skeletal. He tended toward a class 3 skeletal. He had his tonsils, but he didn't report any issues of snoring. And it turns out I knew his wife pretty well too. She confirmed he doesn't snore. I put normal skeletal, but it's really more edge to edge. So we start going down a checklist, and that's what I want you to see at the top here. There's a 2D and a 3D checklist. And the key to unraveling this case or any case, in this case, this was a high-risk case. There were a lot of emotions with this because he had just had 16 restorations done 6 months ago. So I've got to unravel this. But even if it wasn't recent dental work, even if it was just a wear case with broken teeth, someone who's neglected themselves and said, hey, kids are out, or I want a new relationship, or I want to keep the relationship I had, I've retired, or I sold a business, stock, whatever, and they now want to look good, you still unravel with a checklist. And that's the only way you can. But when you learn to do that, all these cases, even though they're complex, they all unravel pretty much the same way. So we're going to go through the checklist. And fortunately, in this case, the joints were healthy. which was a big plus. And he had some, because this was so uneven, he goes, yeah, I am grinding. I am waking up with some headaches. I really wish I had my old bike guard back. And I said, well, let's hold off on this bike guard yet, but let's get going. So the joints, we could do a load test, and in doing the load test, they could accept a maximum load. So we knew the joint was healthy, and that was like, oh man, I know I can help you now. So the checklists are up here at the top, and you're going to see we're going to go through the two-dimensional checklist, meaning we're going to look at the photos. So there were no stable stops. So we checked no. And what I like about this program is I can't go over here without answering yes or no. Now this is obviously not Steve. This is a prototype of a perfect bike. When I take those 21 pictures and I put them in a folder and I go to the Smile Wizard, you'll see in just a minute, they populate through the program. So I don't have to take each photo and put it where I want it. So it's a very simple system. First question is, do we have stable stops? No. Second one is anterior guidance and harmony with envelope of function. Now, a lot of you probably know what that term means, but some of you may not. So let's go through this just for a minute. This gray shaded area, that is the full range of motion that the mandible can make. So we can open wide, we can go forward, we can go up. That's, if we put a pencil on our chin or teeth, we could draw this line in space. This yellow is the area that we function in speaking, chewing, all the things we do, swallowing. So the envelope of function, we know there is interferences because we've seen 5 chips already. And you go, well, he could have just been gnawing on something or chewing ice or grinding his teeth. Okay, but normal chewing, if there's a problem in the envelope of function, porcelain's going to break or teeth are going to break. So there weren't any anterior stops. There was a big slide from CR to MI. So when he's coming off the initial contact forward, he's banging. So there's a problem in the envelope of function. Posterior did not disclude in protrusion. He actually had a molar in the back that drug across the biting surface. They actually did disclude in the balancing. So when we look at this side, it actually did. So I checked yes. But then in the anterior guidance, they didn't disclude on the working side. Now, the good thing about this program is, I don't know about you, but sometimes I get a little confident or overconfident, and sometimes I get a little tired and there are things going on. And so if I don't have something with a checklist, I blow through this and I might skip things because that's our tendency. I've got a really good friend who's an airplane pilot, and I know Dylan, my buddy here, will appreciate the story tonight. He will fly his own plane, and he always has, when I fly with him, sometimes, I'm not a pilot, but he has me sit in the co-pilot seat, even though I couldn't fly the plane. He said, you know, the reason why? He goes, no matter how many years I've flown, it's over 30 years. He said, I go through this checklist every time before I take off. And he goes, I know you'll read every single one. I said, you're right, I will. Checklists are great because they protect you from yourself and they make sure you arrive at the destination properly. So did he have an acceptable maxillomandibular relationship and centric relation? And what does that mean? Okay, it's acceptable. He's not class 1. When you look to the left, he's not class 1. But he wasn't a big class 3 underbite either. So it's acceptable. And we said it's a class 3 tendency. These are my notes. It can be managed. Okay, labial embrasure between the centrals parallel with the midline and perpendicular to the maxillary occlusal plane. No. Now, guess what I'm going to do with this? Besides me figuring this out, guess who else is going to see this? Steve. So besides being a great resource for me, it's terrific for patients to understand. And when they understand, and when you're the only one that's doing this, that lowers the barrier. And if they have any way of affording it, they're going to say yes. So this has been huge in my practice for treatment acceptance. So now we look at this. The answer is it's close, but it's not perfect. He goes, man, they really get into looking at it. It's like, there's a lot of this stuff that's not right. It's like, yeah, well, we're going to get this right. So now is the lower incisal plane in harmony with the posterior occlusal plane? No, it's not. Now, does the maxillary incisal edge have an appropriate aesthetic link to the intervermilion border? No, but guess what? It's not going to. That's the other good thing about the wizard. I knew it wasn't going to be ideal, the class 3. And so, he's not going to get this smile. And some people, depending on, their disposition, I had a lady once that was sure she looked like Kathy Lee Gifford. I didn't think she did, but she thought she did. And it's like, I can't help you with that. I can make your teeth look the best version of you in your face. So when they come in and they want this smile, you get an opportunity to tell them what you can't do, what you cannot achieve before you start. And that helps them understand. So we knew we were not going to get anywhere close to this with him, with his facial structure. This is a handy one because, again, you can adjust these tools on the right, and it's between the lip, and it gives you, he's got a real narrow band. And with his age, I got to be between 50 and 70% closer to 50. But at the same time, I've got to get overbite and overjet. So I only have a little bit of range that I think I can lower these. So, that's a good something to know. And again, this is the tip down smile. His teeth they're just not going to get there. You're going to see when we finish that they don't. But he was okay with that because you remember at the very start, his aesthetic concerns were medium. He wanted to look good. He's a handsome guy, very athletic guy, very attractive wife. His teeth were not matching the rest of him, but he didn't have the expectation that he was going to look like George Clooney, which is another Kentucky resident. So we said, you're going to have to accept the buccal corridor here. It's again like the anterior at the vermilion border, because that's just the way your facial structure is. And then he understood the limitations. So he was like, okay. And guess what? If they don't understand limitations, this is the case you don't want to do until they do, because you can't give everyone this smile on the left, but you can give them the best version for their teeth that fits their face and their situation. In this case now, the gingival contour did not really have proper position and balance. However, it's never going to show. It's healthy. It was not a factor for him. Some people it is. And if you ever start a case and you wind up with laterals that are short and centrals that are long, or laterals that are long and centrals that are short, and everything's pretty, but when they smile, they look terrible, you're going to wish you talked about it ahead of time. Now, this is my favorite part of the wizard, because this is where I get to explain to you about why you have to have a manual focus. So when I'm coming in and focus this manually, the software understands and has that factored in, so that now when I get plaster models and I measure 8.7 millimeters on the model and I tell it it's 8.7, we use these tools where it says drag and the blue and we open and close that to get this proportion, this golden proportion, this 1.6, this 1 and 0.6. So now in his case, it certainly is a little bit of an estimate, but turns out it looks like the centrals are too wide. And so we really want them narrower. Now, next step, if we're going to use this width, and I know it has to be longer. And why do I know it has to be longer? It has to be longer for anterior guidance in protrusion and lateral movements. I have to have the proper amount of overjet, even if he's class 3. So I'm saying, okay, I got to go at least a millimeter. Now you look at this, you say, well, Doyle, that says 72%. You're a Dawson faculty. This is not 75 to 85. What do you mean? Okay, it's not 75 to 85. If I went longer, it would have been less. If I went shorter, it would have been right. But I had a feeling I needed longer. So what this is, I don't want you to get hung up that every case is 75 to 85. But I do want you to understand the parameters you're working in. And if you've seen the movie, it's been out a long time, but it's one of my favorites, The Patriot, where Mel Gibson is fighting in the Revolutionary War, and he's going to go out and ambush the British who are circling his plantation, and all he's got is his 3 boys. And of course, they can shoot, but they're teenagers and they're adolescents and teenagers. So before he goes out, he tells them, okay, boys, remember what I told you when you're shooting? And they go, yes, sir. Yes, sir. Aim small, miss small. He goes, right. Aim small, miss small. Aim right for the middle of their head. Well, this is what we're doing with the wizard. We're aiming small, so we miss small. Okay. So now I've got my 2 measurements, 8.3 and 11.5, and that's where I want to try it in provisionals. Okay. So no black triangles. We're cool with that. Look at the inclination of the teeth. That's another thing to fix. Now, you're probably figuring out where all this is also going to go, because we can export this to our lab technician. So how much do you think my technician likes having this information? When you send these cases with very little information, tell them do the best you can, and then you come back and you start grinding away and the patient's not comfortable and they thought that, you know how I know that? I did one case like that. And I had to do it over. And then the reason I did it over was because it was failing. And I told you I taught at the dental school for 7 years. And I went to the dental school and asked everybody what a treatment plan could be. They didn't know, but they knew the person to send me to. And it turned out he was across the street from me and he was older than me. It's been several years ago. Guess where he had gone? He had gone to the Dawson Academy. And he asked me, where's my photos? Where's my mounted models? All that stuff. So you send this information to your technician, and now he's going to come back to you with a diagnostic wax up that's really close. So the incisal embrasures, they weren't right either. None of this was right. We looked close. I didn't even take the cement off yet because I had a feeling what was going to happen with this case, which I'll tell you in a minute. It did. So I left it just like it was. Now we get into the 3D checks, and now we're on the models. So we're looking 3-dimensionally on our models with it mounted. So we're going to go centric relation, of course, because as we said earlier, for a specialty patient with signs of instability, we know the occlusion is not working. So now we know we have to get the joint stable, and the stable position is centric relation. So think of a bar stool tonight. And if you had a 3-legged bar stool, and you know how one of those 3 legs, if it's off, all 3 of them are doing this. Well, these are 2 legs of the bar stool, the centric relation, the condylar point. And guess what the other leg of the bar stool is? It's the anterior teeth, or it's the occlusion, it's the teeth. So if you get the teeth hitting even and simultaneously when the jaw joint's seated in its proper position at the base of the skull, and the chewing muscles are relaxed, this becomes a load-bearing joint. The forces distribute evenly, the muscles are in harmony, and guess what? Porcelain doesn't break and it doesn't come unbonded. So we're going to go centric relation on this case because he's a specialty patient and the occlusion's not working for him. Now, he accepts the limitations without perio surgery because we talked about we could do perio surgery. He goes, I don't want to do that. And I really felt like that even though he's a class 3 tendency, based on his history, that if we got the occlusion right, the joint's in the right position, and we detailed it, that would work. So we're going to do a restorative correction. We're not going to do orthodontics. We don't need an orthodontic consult. And there's no, sorry, I got some noise here in the background. Let me make sure that goes off. Sorry about that. And we've got, we don't need an airway consult because he doesn't snore. He doesn't have an airway issue. We're going to reshape, reposition, and wax the lower anterior teeth in optimum position. There's our E position smile, and that's how we determine if we can go longer or how much longer we can go. This is going to the technician, and guess what else is going to happen? He's going to do an additive equilibration. So we don't have to take anything off. You might say, well, wait a minute. She opened the vertical. Why don't you take everything off? Well, I'm going to get to that, but it's been 6 months. So I'm not going to take anything off right now. I'm just going to focus on adding back. And we'll explain this at the end. Just hold that thought. We're going to build new restorations, definite stop for all teeth, especially the anteriors. We're going to reshape and restore. We're going to work out the envelope of function parameters in the temporary restorations. And that's an important point. So there are variables, no matter how precise we are, how many checklists I have, no matter how many photos I have, no matter how good and accurate my models are and how accurate my articulator is and my bite registration. This is still a projected one, but I'm narrowing the errors by focusing. So I'm aim small, miss small. So now the technician's going to get all this material. I'm going to package it. I mean, I just punch a button and it goes. Our treatment plan, we're going to save 12, 13, and 21. I felt like I could save those restorations. 23 through 26, I was going to build them up with composite, and then we could keep 28. And then we're going to do equilibration and a bite guard. In addition, we're going to have to do the lower incisors and composite now because of cost. Now, Steve had resources, but let me tell you what else he had. Even though he liked me and even though he loved what I was doing, he had a fair amount of skepticism because he had a case that had failed. And so he's getting ready to spend this money again. So now we have a written report that also goes and it covers that same material I just went through. His chief complaint, broken restorations, history of bruxism and clenching, worn dentition, medium aesthetic return expectations. He clenches and grinds his teeth and been told she does. He knew she did. He knew he did. His first contact was 5 and 28. Mobility on 7 through 10, of course, 7 it was cemented in, but 23 through 26 were also mobile when I checked closely. And then the occlusal stability, none of them. Didn't have stable stops, anterior guidance not in harmony, posterior teeth don't disclude. And, you know, he was an angle, probably a class 3-ish, but he, like I said, he was not an underbite. And he said he never had been an underbite. He'd just been on edge to edge. It's a high risk case. So function is the main priority. Breakage in the first 6 months is not acceptable. We had his shade. And so this is all going to his record. This is where we look at the facial structure. And again, he's not class 1, but he doesn't have to be acceptable. And at this point, I have to restore this case. And we're going to do it in temporaries. So again, we go through all the stuff that I did and I've written this up. So now I send this to the lab and guess what I tell my technician? Do you see that slide golden proportion that says 8.3 wide and 11.5 long? Well, now he knows me pretty well. Guess what width these were when they came back, when I got my Bully gauge? They were 8.3 and it was 11.5. And then he matched everything else. So I'm looking at this and I show it to Steve and I'm thinking, okay, it's got a posterior bridge. We're going to get number 10 out. He decided he did not want an implant. So we had number 10 extracted and we're going to do a 3-unit bridge. And so I'm feeling pretty good about it. And now this is where it's mounted. We've done the minor equilibration to get things CRCO, just a tiny bit on the old restorations. And then the rest of the equilibration is an additive equilibration. That may be a new term for you because we think of equilibration as removing tooth structure, and it can be, but we just had to remove a little bit of the tooth structure on the restorations we're keeping to get those even. And then once we got those even, we could wax in the rest because we were restoring everything else. So now I want to apologize for this because back then I had something on my camera. I couldn't get it off. This is a year post-op. So now you can see he's got composite on the lower anteriors, but his upper teeth are done. And that's what he looks like. Now, why is this way after a year? So let's talk about the other part of fixing another dentist failed rehab. Let's talk about that for a minute. I'm doing good on time. Okay. You know, he was angry. You know, he was disappointed first. First, he was confused. Then he was really disappointed. And then the more he learned and saw the process I went through that she didn't, he became angry. So he said, what do you think I should do? Well, I never answer that. Never. I said, well, you know, what do you want to do? I reflected back. Well, I want my money back. I said, well, I think then talk to your dentist about that. Well, and he had had this conversation before we started with her, and she wasn't having it. And so he came back. Now, what do you think I should do? And I said, well, what do you want to do? He goes, I want my money back. Will you help me? And I said, well, I can't make her do anything, but we need to get your records. So I'll talk to her. So, you know, I told you I taught the dental school, and this dentist was 4 blocks away from me. And you know, I've given CE around, and so I called, and nice cordial conversation. I said, look, there's quite a few issues here. And I approach these from an objective fact basis. And so I just covered the facts. Here's what I saw with his fractured teeth. I can send you the photos. Here's what I saw with the tooth that debonded. Here's what I saw with the bite. Then he lost number 7. What's going on? And so she goes, well, I opened his vertical 2 or 3 millimeters because he's a clincher and he's class 3. And he wanted overbite, and I wanted to do it to see if he could tolerate it. I said, so you just set the pin and opened it up? And she goes, well, yeah, the lab did. And I said, do you have preliminary models? No. I said, you don't have preoperative models? She said, no. And I said, how'd you determine that? And he goes, he did. I said, did you take a Facebook and mount the case on an articulator? Do you have the prep models? No, I don't know what happened to those. She goes, all I have is a wax up. So she sent me a wax up. It was a handheld wax up. Now, you know, without going too much further with that, I know you're on this call tonight because you don't want to do cases like that. But you also know that there are people that are doing this kind of stuff all the time. And I said, okay. So I said, look, he doesn't feel, she goes, if he'll come back, I'll take a look at it. And I said, I understand. She goes, but he canceled a whole bunch of appointments, and he this and he that and he this, and blamed him. Well, now, of course, his side of it was that it was difficult to schedule and they had issues and stuff. So I stayed out of all that. I said, listen, he's not comfortable coming back. And he's not. And I'm not trying to make this worse, but, you know, I think you two need to talk. And she says, well, I'm not giving him his money back. And I said, I didn't tell you how to give his money back, but I think you two need to talk. I said, because we're going to have to redo this case. And fortunately, the case that happened to me, my patient didn't get upset and I caught it. I was able to get it out of the ditch and then go to the Dawson Academy. In her case, it came to another dentist. Now, if you're doing cases without following these steps, listen up, this can happen to you. And if on the other side of it, you're here tonight and you are the receiver of these cases, here's how you do it. You know, you follow these rules. So now I said, okay, well, then, you know, if I can ever help you, let me know. I really wish we could get a dialogue going between you and Steve, because I think you two need to talk. So now we get a year out, and I've not had anything break. And I'm pretty surprised, even with good occlusion, that composite bonded to those butter knife veneers has not chipped or broken, but it didn't. I was really happy with that. And so now you're going to say, well, these are pretty thick centrals. It's like, well, I had to bring them out, and yeah, they're pretty thick, but guess what? They got occlusal stops and they got overjet, overbite. So, and you're saying, well, how did you know? He wore temporaries for 3 months. So because I aimed small and missed small, then I put him in those temporaries that were centrals were 8.3 and 11.5. And, you know, we made small adjustments, but once after, I think he came back 2 times the first 2 weeks, which we plan. So when I do these cases, we tell the patient, You're numb today. We leave with temporaries on. I know they're close. I see them the next day because I want to see them when they're not numb. And we perfect it as best we can the second day. And then we say, I want to see you in 2 weeks. And if something happens, I want to know about it. Speech, chewing, bite, breakage, anything. You don't have to wait 2 weeks. They come back in 2 weeks. We start talking real critically. How do you like them? How do they feel? Let's get you to say Mississippi, 61, 62, 63. Let's get you to say 51. Let's check the F for phonetics. If any of those things are off, we're doing it in plastic. And we spend time, and sometimes they take longer than others. Point is, you've gotten close with your diagnostics, you perfect it with the temporaries. And in Steve's case, I said, you're going to wear these for 3 months. I'm getting ready to tell you why. Well, the why is because she opened the vertical, but I'm going to tell you more about that in a minute. So now at the end of the year, he says, I'm going to sue her. I said, okay. He goes, will you help me? I said, well, I've got all these records. So now here's another reason I'm not, again, we get nothing from the Smile Wizard. Usually that would send chills down my spine before I used it. But now I just had to push a button and export it. So I sent all that to the attorneys. I had it all done. You say, well, how long did it take you the first time? Well, my staff helps me with the records. And then I sit down and I can do these at home. It's a cloud-based program. And I'll sit down and I'll look at these for 30 to 40 minutes, type it all up. But I do it once. And now it's a legal record. It's a case presentation record. So when I present the case and I'm the only one doing that, whether the case has failed or not, you just don't get to know if the patients are ready to go and they have the finances. They just don't say no. The third thing, it's great for your technician. He or she can help you. And then if you do get in a legal bind, it's done. So it really saves time to take the extra time at the start. So now that's what his composites look like. So now here we go, 5 years post-op. So what ended up happening is he sued him. He sued her. Now we get the attorneys involved. They came out and said, hey, we want to see your stuff. So I did a 4-hour deposition in my office. I said, I'll do it, but bring him. I've got a conference room, and because I teach, I'm set up for that. And I've got the audio visuals. You may or may not be, but I do this a lot. So I said, you guys, both sides come out here to my office. I did a 4-hour deposition. And they swore me in. Well, when the deposition was over, the opposing counsel asked the attorney, said, can we talk to him, but not about this case? So the attorney for Steve said, sure, because normally I wouldn't have done the deposition as the treating dentist, but his attorney said, I also want you to be the expert witness because I read some things, that I teach. So the attorney says he can handle himself. So I went out in the hall and the lady says, now, not about this case, but we have some other cases. Will you be our witness? Because we've never seen a program like this or any workup like this. Generally with dental cases, it's a disaster for the records. I said, sure. So guess what? Both sides call me now for that, which we'll get into that later if you want. But anyway, so then Steve got a settlement because after that deposition, the opposing prosthodontist, who was chairman of prosthodontics at UK, resigned from the case and said, I can't defend it. So he got enough in a settlement to get paid for the work the 16 restorations he did, then to pay my fee for all the restorations he did. He paid the attorney, and he had enough money left that we both like bourbon, and whenever I see him, he buys me a shot of Pappy Van Winkle. And if you're from Kentucky, you know what Pappy Van Winkle is. So, and now he's retired, so he's got a tan, he's fishing and playing golf. This is 5 years post-op with all the restorations. So when he got the settlement, we did the lower veneers. And so now, look at him smile. And so we were able to do some things aesthetically within the parameters that is obviously working because it's 5 years. Nothing has come off. Nothing is chipped. Nothing is worn. Nothing's breaking down. Now, we did not get those front teeth to the vermilion border, but hey, we knew we weren't going to. He didn't care. And So it's just been a wonderful case. I cleaned the cement off a little better than the other dentist. I couldn't resist that one, but everything just worked super. So let's talk about vertical dimension here in the time we got left. We got about 5 more minutes and we're going to open up for question and answer. Key to this case is understanding vertical dimension. Vertical dimension is related to muscle. So the repetitive contracted length of the muscles is what determines vertical dimension to which the teeth erupt. So think about it. When a child loses his teeth, they're growing, new teeth come in, they erupt, they touch muscles. Okay, that's vertical dimension. When the teeth erupt, something stops them. Now, when teeth and muscle get into a conflict, the muscle always wins. How do we know that? We know that because the muscles will get stronger to the point where they ache a little bit, but they'll get stronger. They don't tear. The joint may break down, but the muscles, I've never had a torn masseter, but I've had joint problems. I've had torn disc and cartilage, meniscus, had that. What else breaks? Teeth. Teeth break, crown breaks, teeth move, all that stuff. So muscle wins every single time. Muscle determines vertical dimension. Okay. Even with rapid abrasive wear, you don't lose vertical. This is the hardest thing for me to understand. Let's make this clear on this webinar. I didn't write this textbook. I read it. This textbook is the functional occlusion from TMJ to Smile Design, and chapter 13 covers vertical dimension. And I entered the whole chapter in the record of this case when I did the deposition. That's why the prosthodontist resigned as the other side. Vertical dimension is unrelated to comfort, okay? And you cannot unload the TMJs by increasing the vertical dimension. So when a patient's uncomfortable, that does not mean the vertical dimension's wrong. That means there's interferences in the bite and there's parafunctional activity, or there's been breakdown in the joint and the joint's damaged and the disc is not in place, so the ligament's torn and there's bone-on-bone contact. But that doesn't mean you change the vertical. That doesn't mean if you do change the vertical, you're going to help. And you don't unload the TMJ, you just bring it out of the socket. So the condyle position affects the vertical this way. When they're in MI, the joint's not in the fossa. Teeth are touching. Here's the muscle link. That's vertical. But what happens when we put them into CR? Well, we put them into CR, they touch, but the muscle link stays the same because the definition of CR is when the joint is stable, the disc is seated, the muscles are relaxed. We apply a load test, there's no tension or tenderness, so the muscles are flaccid. So the muscles are not contracted, and the joints in the fossa, the teeth touch, that's vertical dimension. And so in this case, was the vertical dimension of occlusion altered in this case? I wish I could see your faces and, get an answer from you, but I'm going to give you the answer. The answer is no. Vertical dimension was not because it was related to the muscle. So how did I do this case? He'd had 6 months. So I knew at about 6 months, things were closing. I knew they were. Maybe not all the way, but I knew they would. I also knew it took a good 6 weeks to get a decision from Steve. So in that 6 weeks, I'm just kind of crossing my fingers that nothing else broke. Once I got a decision and scheduled him and got the wax up done, that was another month. Okay. I know things are changing. I know the alveolar process, and I know this is changing. I'm monitoring for symptoms. Then I go in and restore and rebuild, and I place them in temporaries for 3 months. Now, at the end of 3 months, I'm checking everything. I'm checking with a load test. I'm checking the joint. No clicking or popping, no muscle pain, no clenching and grinding. He's not reporting headaches, and nothing broke. Guess what? I'm at vertical. How do I measure that? I measure it by using my brain and looking at the patient and following the steps. If I had any problems in that 3 months, I would have gone longer. If even though I aimed small and missed small, I had to recalibrate, I would have done it in the provisionals. So that's the protocol for success. So the first thing you do is you decide, is it a negative occlusal exam? Are there no signs of instability? Then go right ahead and work an MI. You may say, is that a Dawson faculty saying I don't have to equilibrate? I don't either. But if I see signs of instability, wear, mobility, migration, sore muscles, broken teeth, in this case, well, now I've got to verify centric relation, make sure the joint's healthy. And since the occlusion is not working, I've got to start centric relation and work out an ideal occlusal scheme. Now, if I cannot load the joint, there's medial pole issues and it's non-verifiable and there's pain, tension. I may have to image the joint, get the joint stable, and find stability before I can fix the occlusion. Okay, so the Whittiam rule comes into play. Pete made this acronym and it means, would I do it on me? And the answer is we should focus on doing the least amount of dentistry to solve patients' problems and provide them with what they want. Now, when you say do the least amount of dentistry, you can't stop with that, because some patients will want the least amount and they'll want you to present an alternative treatment plan. And despite the fact that Steve and I were friends, he asked me a zillion questions about, could we do this? Could we do that? Could we do this? Could we do it differently? I have to solve your problem, Steve. So the least amount was solving his problem and using composite resin for a year or so. And once he got settled with his legal issue, and once he saw that this was working, then he felt confident we finished it. But I told him eventually you're going to need the whole gamut. There wasn't any compromise. So we do the least amount of dentistry to solve the patient's problem. And that's a key point. For specialty patients, here's the pathway. We do a complete exam and records. We go through a 2D and 3D checklist. We look at the photographs. We're precise in how we take the photograph. You don't have to use the Smile Wizard, but you got to use tools like that. You got to be very precise. You got to do a 3D treatment plan with mounted models where you're looking at this case in 3 dimensions. Then your best guess, you do a wax up, you do provisionals, and you're super focused on the provisionals. Once you get the provisionals right, once the patient's happy with them, once the phonetics right, once the function's right, everything's good, you can impress or scan those, do an incisal guide table for the lingual contours, send that to your technician, and they can duplicate your provisional. So now when you cement the case, you're not sweating. Cement day is the best day because you know it's going to work. And that's where your communication has to be super with your technician. If you're struggling with cases when they come back from the lab and you're struggling in the mouth and you're doing all this adjustment, well, you can say, well, the lab this, lab that. Well, let me tell you something. The lab's going to give you based on what you give them. So when I give them this result, cement day is party day because we cement them and, we touch very little, very little. We see them the next day, very little. And then 5 years later, your patients come back with a tan and they're still thanking you. So that's how we do it. Going back to the envelope of function, his interaction did not look like this because he had this class 3 tendency, but it didn't have to. It did have to have a centric relation position. It did have, for him, the correct incisal edge position with long centric, meaning when he bites down, there was no interference. When he chop, we made sure this contact between C and D was not in the way. Smooth protrusive path, smooth lateral guidance. So the formula, lines in the front, dots in the back, joint in the socket, muscles relaxed. And that's what it looks like. Okay, your next step. If you have not started this journey and you want to, your next step is occlusion and smile design. And Lenny Hess, our curriculum director, is going to be the lead faculty. I will be there with Lenny talking about some things on the practice management side with how to communicate this positively with dental benefits, how to get yourself out of managed care if you want to go fee for service, but we're going to be there. And this is your next step. And if you take that step, we have a curriculum that if you thought that I had a step-by-step process developed by Pete Dawson, now this wasn't developed by Doyle Freano or Lenny Hess, we also have a teaching program that step-by-step that'll take you to the point where you can be confident and competent in your results. Okay, Dylan, that's all I've got for tonight. I made it before 8, but I've got as much time for questions as you all have them. So if you'll put that up, and I've got the chat box. Oh, Annie, I just saw you this weekend. It's good to see you. How did you prepare the lower porcelain veneers to accept the resin bonded? Well, real carefully, I got the yellow, super concentrated 30-degree etch that you put on inside of crown. Didn't let it hit the tissue, isolated it, and then bonded it and got it perfected. So that's how we did it. And I'll be honest with you, I would have been confident had that been on enamel. But that just goes to show you not so much that, I mean, I did use the porcelain etch, and I did do the bonding agent. I did do the drying agent. I did all that stuff. But that shows you how powerful, when you get the bite right, that that it can work. Okay. Let's see. Thank you for the compliments. Yes, I did make him a bite guard. And the reason I made him a bite guard, I did 2 reasons. One is it's a lot of glass, number one. And number 2, he said, I've worn a bite guard all my life. I want to. And I thought that would be silly not to. So I did a bite guard in CR, anterior guidance, even contact. So yes, that's a good question. Appreciate that. The Q&A. When doing full mouth crowns, how do you sequence the impression, keep the final crown same vertical as provisionals? Do you need to keep a posterior stop with posterior teeth taking impressions, or can you take a full arch impression? All right, that's a good question. The way we did his case, okay, I had him come in and I had this diagnostic wax up and a putty bite. So we prepped all the teeth on the upper arch one morning. I did temporaries on the upper arch. That night, he went home with a quick splint. Came back the next day, we prepped everything. You know, you're asking me how I keep the vertical, and that is when I prep, I'll take a bite registration after I've prepped a couple of teeth, and then I set the bite registration to the side, and then I add wax when I prep other teeth and put it back in. So I do a sequential bite registration that way. You come to our courses, we'll explain it, but we use Galar wax, and so we heat it. And once I've prepped a few teeth, I'll go in with a bite registration in CR. I already know where the pin's going to be. And then I record the ones that are preps. I don't touch those preps again. Then I come back and do more preps, and then I sprinkle in or drip wax in and finish the back bite that way. Now, to do the case, I decided to do canine to canine on the upper anterior first and lower composites, and then temporary posteriors in plastic. So he wore the temporaries, like I said, for 3 months. And then when I went to restore the case, I went from canine to canine and put the 6 anteriors in, leaving the temporaries that were working. And then I did one side, upper and lower, cemented that while he still had the plastic on the other side. And then I did that side. That's how I sequenced it. I hope that answers your question. If not, type another, ask me again. Is a T-scan used similarly to Smile Wizard? T-scan's great. Yes, I did not have it then. I do now. Absolutely. T-scan's wonderful. Again, we don't get anything from them from that. And I had the T-scan about 4 years. I didn't use it on his case, but I absolutely think the T-scan's awesome. The T-scan's also awesome when they have a bite issue, and they'll tell you they have a bite issue, but they're not sure you're the one that can fix it. When you pull that tool out and this tooth is 30% and this tooth is 5%, and they see all that, yes. T-span, yes. 3-month period standard before switching from temps to definitive restoration, or can it be done earlier? Okay, yes. 3 months is not standard. 3 months was me this time, and my clock was running from the first day I saw him. Again, I told you I had about 6 weeks to get a decision, about a month for a lab wax up. I knew he'd had this case for about 6 months. So now I gave him to when I knew his vertical had been a year. And I knew there had been dental alveolar correction, even if I couldn't necessarily measure, I just knew. So, but typically when I'm doing a case like this, I want them to wear the temps at least 2 weeks, at least. No more. If they're having problems, then we just keep adjusting it. And some patients we have to adjust more. No matter how precise we are, it's an estimate. But typically within the 2 to 4 week period, I try to get them out of temporaries in a month. I don't like it for the tissue, but I like that 2 to 4 week sweet spot for me. Do you ever have problems with retention of composite? Well, you're probably not going to believe this, but not really. I really don't. And that was the first time that I had done a high risk case bonded to the to ceramics. When you're bonding that on teeth, no. I've had cases where they didn't want to do, they wanted 4 veneers, let's say, and the canines were okay, and I bonded composite to the lingual of the canines where it wasn't aesthetic. Got proper lateral and protrusive, and 10 years later, it's still there. So yes, you can. Is it gonna chip? Yes, it will chip. But I always present that as this is not a definitive restoration. This is a transitional restoration. You will have some issues with it, but if we need to phase your case, it's acceptable. For a patient with obstructive sleep apnea, does restoring eccentric aggravate the bruxism? Why would it? That would be my question to you. If you're eccentric, you're never going to aggravate the bruxism. If you're not eccentric, let's define that for a minute. If I'm eccentric, let's define it. I have even and simultaneous contact on all the teeth, jaw joint seated in its proper position at the base of the skull, hinging. So I've got 2 legs of the bar stool, third leg of the bar stool. It's hitting like this. No, it's not going to aggravate it. Now, will it stop the bruxism in obstructive sleep apnea? Probably not. So those patients do need to treat their sleep apnea, and they do need to have a splint at night. And even the splint, that can be a problem because it's restricting the airway. So for those patients, I would rather have them in a CPAP. I would feel confident in a CPAP with equilibrated occlusion. Now, if they could tolerate plastic, meaning a splint, and a CPAP, and an equilibrated bright, yes, that would be the best because those are high risk. But you're not going to worsen the bruxism being eccentric. You're going to have more bruxism when you have an erratic, unstable occlusion. That when that, let's think about this for a minute. Why do people grind their teeth at night? We always say, well, they grind their teeth at night because they're stressed. Well, let me tell you something. We're all stressed a little bit. Why do they grind their teeth at night? The answer is when they go to sleep at night, they relax, jaw falls back, and they continue to swallow 100, 200 times a night. Guess what happens when they swallow and they're relaxed? They hit the first contact. Guess what happens then? They hit, they rub a little bit, and they let go. If you look at sleep studies, they're hitting and bruxing for 5, 6, 7 seconds. But in Kentucky, when the Wildcats lose and we get cold weather and there's a problem with, the dog, or my child calls and there's an issue, as my stress escalates, now what happens? I swallow, I hit, and I don't grind 5, 6 seconds. I grind 10, 12 seconds. Okay. Now 150, 200 times isometric exercises. Try that tomorrow. Press really hard like this, about 100 times, really hard, hold it about 10 seconds. You'll be so sore tomorrow unless you're a weightlifter. So that's why the symptoms peak and patients say, well, I'm grinding because I'm stressed. No, you're grinding because your bites got an imbalance. We always say your alignment is this, your balance is this. So if your tires are out of alignment, you're veering off the road. If your tires are out of balance, you're welts. So you're grinding because of that alignment balance problem. You're grinding enough to be symptomatic occasionally because your life goes up and down like everybody else's. So I tell them, I can't solve that for you, but what I can do is create an environment where you got to remember now, when you bite down and squeeze an MI, joints out of the socket. When I bite down and squeeze and my joint's in the socket, this is a load bearing joint. That's why we do a load test. So now some of the force here is transmitted properly through the joint and it distributes the force. So we're never going to cause a problem by having a patient in centric relation with a healthy, stable joint disc relationship. I will talk on that all night. I probably shouldn't. So we've got plenty of courses and we'll spend a lot of time with that.